Welcome, everyone. We're very excited to have you here joining us for our the next installment in our webinar series, Modulator Use in Pregnancy and the Impact on CF Newborn Screening Results. And we're honored to have our two speakers, Drs. Jennifer Taylor and Dr. Clement, and we'll introduce them in more detail right before they speak. And I'm joined by co-moderators Megan McGarry from Seattle Children's and Yvonne Keller-Gunther from the Center for Public Health Innovation. She works here with me. I'm Marcy Sontag. We're very excited to have you here. And as I mentioned, this is a part of our larger cystic fibrosis webinar series. The first QR code is for our CF project site if you want to see other resources that are available for cystic fibrosis newborn screening at the Center for Public Health Innovation. Or the bottom QR code is for our YouTube channel. And we do have a series of webinars that are available on our YouTube channel related to cystic fibrosis newborn screening. So broadly, CF newborn screening, as this group I think is very familiar, begins with the blood spot being collected, tested at the public health lab, and then communication of positive results. And really, this series today, or the conversation today, is going to be across the board. After it's collected, then we have the testing in the lab. How do we communicate about the appropriate testing, and then the communication of the positive results? And all of this is really impacted by CF modulator use. So I'll hand it over to Megan to chat a little bit about that.
Nice to see you all today. So this is really a new era of cystic fibrosis. With CFTR modulators over the past decade, we have now seen that many different types of pregnant people have been on CFTR modulators. And we're going to talk through some of those different scenarios. And because of this new area of medication treatment, clinicians may be very experienced, never have heard of modulators, so many different levels of experience working with pregnant people. And so treatment is really variable. And this has become really impactful on newborn screening and how we handle this because modulators do affect newborn screening results in certain populations. And the most important thing of newborn screening is really communication. So everybody knows what's happening and that results get communicated correctly. And communication systems around modulators really have not yet been developed. And this is really important because newborn screening results may be falsely normal. So as a teaser, we are so excited to move forward with our talk.
Oh, we're going to start with a poll though first. And so I'm launching a poll just to see what's the experience of this group. And so hopefully the poll, you can see the poll and enter your answers on your screen. We just want to understand how often people have had experience with newborns and mothers who are using modulators. How many times have you ever had a false negative related to that? And if you have other answers, we'd like to know what worked well and what didn't work well related to this, how you responded. So there are 2 longer answers there that you can type in. And then finally, we want to know, where do you work? Where is it that you're from? Or what group are you representing? And so since we have put in some longer answers here, I'm going to leave this poll open and let Dr. Taylor present her information for the modulator use, and we'll come back with this poll open and close it after Dr. Taylor presents and give you the results. So that gives you some time to, if you have questions about what worked well and what you would do differently, we can talk through that. So with that, I'm very excited to introduce Dr. Taylor. She's a tenured professor of adult and pediatric pulmonary medicine at National Jewish Health, where she serves as the medical director of clinical research services, immediate past president of the medical staff, and is co-director of the Adult Cystic Fibrosis Program and director of the CF Therapeutics Development Network Center. Dr. Taylor, it's all yours.
Okay, great. So thank you so much for having me, and good morning or good afternoon, depending on where you are. I'm going to talk a little bit about the safety or what we know about the safety of CFTR modulators in healthy controls and pregnant people with CF. So these are my disclosures, most of which are related to the fact that I run a lot of clinical studies, including some of the ones for Vertex for these modulators. So our objectives for today are to identify the potential scenarios for in utero CFTR modulator exposure, review the safety of modulator use in healthy controls, define the potential maternal and fetal risks of modulator use in pregnant females, and then examine available data from pregnant females with CF who have used CFTR modulators. So there are a couple different scenarios under which a fetus may be exposed to CFTR modulators. The most common one that we see is a female with CF who is taking modulators for her own health. And of course, her baby is therefore an obligate CF carrier because the mom has CF. We have also, and including in a study that I'll talk about called Mayflowers, seen females with CF whose partner was not tested ahead of time, and then it turns out that the baby has CF, and the baby therefore was exposed to modulators for the entirety of mom's pregnancy. So they are being essentially treated in utero. A scenario that's come up more recently in the literature, and now we're actually designing a study to examine questions about this scenario, is the female CF carrier whose fetus is diagnosed with CF in utero, either because meconium ileus is seen on prenatal ultrasound or because they do non-invasive testing such as cell-free DNA or amniocentesis because the parents are known carriers. So in all those situations, there's exposure of the fetus to the CFTR modulators. In the case of the carriers, that exposure occurs later because people aren't generally diagnosed. They can't really be diagnosed in their first trimester since even cell-free DNA can't be done until the end of the first trimester. So the female with CF who has a fetus with CF, female with CF whose fetus is a CF carrier, that exposure occurs generally from conception versus the female CF carrier in which the modulator is started often in the second or third trimester, as you'll hear a little bit more about later. So let's first talk about the use of CFTR modulators in people without CF, because we do have a little bit of data on that based on the fact that the sponsor had to test this drug in healthy controls before they tested it in people with CF. Unfortunately, in spite of the FDA recommending that males and females be included in these healthy control studies, sponsors often for ease because of menstrual cycles only use males. So unfortunately, there were only males in these healthy control studies, but nonetheless, they were healthy controls. And this slide is busy, but it's basically all of the side effects that were seen in those healthy controls when they were exposed to VX445 Tez-IVA or ETI, elexacaftor, tezacaftor, ivacaftor, known as Trikafta. So you can see that the common adverse events, like one person basically, the ones that were over 10%, were things like diarrhea and nausea, things that we know about for those of us who have treated people with CF with these drugs. There were also some rashes, but generally people tolerated these very, very well. And there were no serious adverse events in any of these healthy controls, and there were no liver function test abnormalities. So as we start to think about using these drugs in pregnancy, we have to again think about two different scenarios. So in the case of a female with CF, our goal with using these drugs is to treat the condition of the female, so the person with CF. So the risks and benefit ways are a little bit different. So if you continue CFTR modulators during pregnancy, of course, there are relatively unknown risks to the fetus based on a paucity of data in pregnant people because pregnant people were excluded from all of the phase 3 trials. And if someone became pregnant during the trial, they were removed from the trial. But if you discontinue the CFTR modulators during pregnancy, there's a risk of health decline. There were previous reports that because these drugs have quick onset, they also have quick offset, and people can become quite ill when they suddenly stop their modulators. Also, a concern is that if someone gain weight on the modulators and you stop them suddenly, they may not gain weight adequately during their pregnancy. And this was a frequent problem for pregnant people with CF in the era before modulators. And of course, there's also the risk of for the infant or the fetus, if the mom's health declines, that can also impact, for example, if they're hypoxic, that's not great for the fetus, or if they have to take other IV antibiotics, those can be a risk for the fetus as well. Now, that's if the person who is pregnant has CF. If the person does not have CF, again, weighing the risks and benefits is a bit different. So for continuing modulators, you really are doing this for the fetus if the mom is just a carrier. So based on animal data, there's potential rescue of meconium ileus. In fact, in the CF ferret, 100% of the ferrets who received in utero modulators resolved their meconium ileus and did not require surgery or die after surgery. You also may rescue pancreatic function, and in the animal models, they were also able to rescue the vas deferens of the males because, of course, about 98% of males with CF are born with congenital bilateral absence of the vas deferens. But if you treat ferrets in utero, you rescue the vas deferens and therefore restore their fertility. Of course, there's also still the unknown risk to the fetus based on a positive human data, but the risks to the female are different if the female does not actually have CF. There's one, the risk of pressure and willingness to use an unproven and unapproved therapy, because of course these aren't approved for use in pregnancy, nor are they approved to treat the fetus. There's risk of side effects such as rash, and again, elevated liver function tests, as we've seen in people with CF. There's also some question of neuropsychiatric side effects, such as increased depression and anxiety in a small subset. And I think that one of the biggest problems is the cost of the drug, which is about $300,000 per year. And if the insurance doesn't cover it, then there's suddenly pressure on that family to try to come up with the money for that. And of course, that's out of reach for most people. So I just wanted to give you one example, and this is a slide courtesy of Dr. Wren, who you'll hear from in a few minutes, about a case where there was actually a problem for the person without CF, the CFTR carrier mother who developed drug-induced liver injury. So she started taking Alextezaiva or Trikafta for prenatal treatment of her fetus at 26 weeks gestation. And then you're supposed to check liver function tests monthly when someone starts them. They were being checked, and hers started to be elevated. They were elevated still postpartum, and when she had a liver biopsy, she had autoimmune hepatitis and had to be treated with monthly prednisone. And we have again seen this in a rare number of people with CF who've taken these drugs, which is why we're supposed to check liver function tests monthly. It doesn't happen often, but it is a risk that you need to discuss with people. So this again is a busy slide, but I just wanted you to understand the way these drugs were tested when they were tested in animal models. So all sponsors are required to do animal reproductive toxicity studies for their new drugs that they are trying to get approved. Importantly, when they did this, the sponsor did this, they tested these drugs individually, not in combination. So on the left-hand side, I'm showing you the sexual and reproductive health impact that's being studied. So chromosomal abnormalities and pregnancy teratogenicity. And then along the rest of the columns are the individual drugs. So there's no evidence of genotoxicity with any of the individual drug tested in animal models. And the other thing that the sponsors are required to do is to say how much compared to the maximum recommended human dose, or the MRHD, how much of that did actually lead to toxicity in the animal models being studied, which were generally rats and rabbits. So the bottom line from this very busy slide, so I was just trying to do full disclosure of what doses were tested, is that there wasn't any teratogenicity seen at normal human doses with any of the drugs. And this is, you can look at this in the United States prescribing information for any of these drugs, the USPIs. So now let's switch to talking a little bit about pregnancy in people with CF, where we do have more data about the use of modulators just because the drug was approved back in 2019, and it does increase fertility in females with CF. So we have seen a lot of pregnancies. So we went from 200 or so pregnancies a year to about 700 pregnancies a year once that drug was approved. But as we start to think about what happens when someone takes modulators during their pregnancy with CF, we need to understand the complications that were seen in pregnant people before they were ever exposed to modulators, because people with CF did have increased complications, as did their infants, in the era before modulators. So for example, from relatively large databases, and again, back then, that there weren't that many people becoming pregnant. So these are generally less than 100 people. But we did see more maternal complications in the pre-modulator era, specifically more diabetes, more infection, more preterm labor, and more gestational hypertension and preeclampsia. And in the infants, we saw increased rates of congenital anomalies for those born to females with CF, particularly cardiac anomalies. We saw more jaundice in those infants. More often were they born via C-section, and they were more often premature. In a more recent database that was done out of the UK, they noted that the lower someone's lung function, the more likely they were to have a preterm baby who had low birth weight. So again, this is all in the pre-modulator era. As we start to think about the modulator era, when many, many people with CF are staying on their modulators during pregnancy, it's important to recognize that the fetus is seeing the full dose that the mom is taking. So this is data from Aaron Trimble, and on the y-axis is the concentration of the various modulators. On the x-axis is the 3 different ones that are in Trikafta or Alextezaiva, so ivacaftor, tezacaftor, and alexicaftor. The circles represent maternal cord blood or maternal blood, the squares, cord blood, and the triangles are infant blood. And you can see again that mom and baby have the same levels essentially of these drugs. So the full dose is being seen by the fetus. So because so many people are staying on their modulators, we really, really wanted to get data about the use of modulators during pregnancy. So the Mayflower study, Maternal and Fetal Outcomes in the Era of Modulators, is actually studying people with CF who become pregnant and following them through their pregnancy, as well as for 2 years postpartum, and also following their infants for 2 years postpartum, so that we can understand what the outcomes are for these pregnancies. And it's the first time there's ever been a prospective study of pregnancy in people with CF. And sorry, there's a little bit of delay in slides. So, okay, let's see if we can go forward. So this is some preliminary data. We'll be presenting the full pregnancy data, hopefully at the North American CF Conference later this year. But this is looking at modulator use during pregnancy. So you can see that the overwhelming majority of around 300 women who were in this study used modulators continuously throughout their pregnancy. And the majority of them were on Alextezaiva or Trikafta. So what did the delivery outcomes look like? So at the point of this data cutoff last year, there were 280 live births. Their average gestational age was 38 weeks, so full term. There were about 23% that were preterm. And again, I told you this was a common occurrence in the pre-modulator era. And something that's different about this group is that previously we recommended that women who had an FEV1 lower than 60% did not give birth. In our Mayflower's cohort, there are people whose lung function is low as 28% who actually had pregnancies. So we have a sicker group of people than we used to see who were able to continue their pregnancies. There were a low rate of miscarriages and stillbirths and very few abortions. So looking at infant complications in the first 6 weeks, again, this is preliminary data. You can see that we did see some extended hospitalizations. We saw jaundice, preterm birth, again, things that we'd seen previously. There were infants who had congenital cardiac defects, and there was some hyperbiliary and hypoglycemia, but not extremely high rates of any of these things compared to what we've seen reported in the literature for people who don't have CF and are giving birth. Another thing that we're studying, because you can't do full neuropsychiatric testing in 2-year-olds, so the most that we can do right now is to look at infant milestones. And so these are the self-reported by the moms of the babies meeting their milestones that everybody does at their pediatrician's office. Previously, the CDC recommended that you look at how many met their milestones, like at 50%. More recently, they've said to try to catch neurodevelopmental delay early, they said we really should look at who's meeting 75% of their milestones. And we don't have all of the data out to 24 months. As you see, the ends get smaller because we're still following all these infants. But the majority of the infants are actually meeting their milestones at 75%. And we'll continue to collect this data out through 2 years for all of the babies that were born. So another thing that we'll have to think about, and that we are thinking about, is the current approvals for CFTR modulators. So the mom is taking this, again, off-label, But what happens when the baby is born? How does the baby continue to get modulators? So if the baby has variants or mutations that are responsive to ivacaftor, basically they can start taking ivacaftor at 1 month of age. Lumacaftor, ivacaftor, or Orkambi is approved down to 1 year of age, and Alextez-Iva or Trikafta is approved down to 2, with the most recent once-a-day modulator that's very similar to Trikafta being approved to 6. So once the baby is born, the question is mom going to stay on the drug and continue breastfeeding to expose the baby, or are you going to off-label direct dose some of these drugs, or can you obtain access some other way? But you do really have to have this conversation before you ever start somebody on modulators if it's a mom who does not have CF herself. So what do we know? Again, going back to animal toxicity data, what do we know about modulators and breastfeeding? So from the animal models, we do know that all of the modulators are present in breast milk, albeit at lower levels. For those of you who don't use these modulators regularly, it's important to recognize that there is a black box warning on any medication that contains ivacaftor, which is all of them, because when they gave baby rats direct dosing of ivacaftor, they developed cataracts. That's, again, a CF, non-CF model. It's an animal reprotox model, but they gave those rats the ivacaftor, they developed cataracts, so there is a box warning about that. The other thing that's in the United States prescribing information is that when they gave juvenile rats tezacaftor, so again, that's both in Tez-Iva and Alex-Tez-Iva, so in Symdeko and in Trikafta, they saw at 1.9 times the maximum recommended human dose, seizures and death in these neonatal rats. We have had 0 reports of any of that in any infant that's been exposed, but again, that's in the United States prescribing information. Oops, sorry, there are comments popping up. So something I wanted to point out is that we have actually looked at this in CF models, CF animal models, including ferrets and rats. And we did not see any cataracts nor any seizures in any of the CF ferrets or the CF rats that were direct dosed with these modulators. So I do think it's probably a circumstance of the type of animal that's used in these reprotox models, but again, it is in the USPI. So again, I just want to point out, this is more data from Aaron Trimble, that when you look at breast milk, which is the bottom graph here, if you look at the concentrations, those concentrations in the breast milk and then in infant blood are much, much lower than you see when the baby is actually in utero getting exposure because the mom's taking it. So breastfeeding does allow some exposure, but it is not the same level of exposure. And as the infant grows, of course, the milligram per kilogram exposure is much, much lower from the breast milk. And as they start adding food, again, that goes even lower. So it is insufficient, most likely, to sustain the effects of the modulator to just be breastfeeding for a prolonged period of time. But it may affect your your sweat testing and other results. So we looked retrospectively at data to see what happened when moms were breastfeeding with CF, and their breastfed infants did not actually have a high rate of cataracts, although we only know of formal testing in 6. There weren't any modulator-related liver function test abnormalities in the breastfed infants. There was one case series reported out of Israel and UT Southwestern where 3 of 23 infants who had cataract testing had small, non-functional cataracts that wouldn't have been picked up otherwise. So whether this is related to modulators or not is not clear because, of course, there wasn't a control group. But again, this is something we will be looking at in the Mayflower study, and it's not something we've seen in the studies where ivacaftor was direct dosed to humans. So what are our knowledge gaps about use of CFTR modulators in pregnancy? We don't know whether brain accumulation of CFTR modulators that's been observed in rats treated in utero is relevant to the human fetus. We don't know very much about the pharmacokinetics of CFTR modulators in pregnancy because obviously there are huge fluid shifts during pregnancy that affect any drug metabolism. So those are under study and not yet known. The critical time point for initiating CFTR modulators during pregnancy to effectively prevent complications for the fetus with CF is also unknown. And in an infant exposed to CFTR modulators in utero, the minimal effective dose to prevent withdrawal syndrome post-birth. I told you that people can get very sick when they go off their modulators. We don't know what that minimal effective dose is and how long breastfeeding is a sufficient dose to maintain their, for example, pancreatic function if they're born with pancreatic insufficiency. Also, the safety of administration of ETI to children and infants less than 2 years is relatively unknown and still under study. Although there are case reports of infants being direct dosed with Alex-Tezaiva. So we are actually trying to prospectively study the use of CFTR modulators for in utero treatment of the fetus. It's a prospective 2-part observational study design that is currently being planned through a planning grant from the CF Foundation. And we're really trying to figure out whether or not if you begin this treatment during pregnancy in the carrier mom for the fetus, if you can prevent the complications of CFTR dysfunction. Our outcomes are going to be meconium ileus requiring surgery or any kind of intervention. I told you in the CF ferret model, you could prevent meconium ileus 100% of time requiring surgery. Also, they were able to rescue pancreatic function to some extent, and we'll study that. We want to see if boys are born with their vas deferens, and we'll also look at growth, safety, and tolerance. We'll also assess whether or not breastfeeding is sufficient to allow for babies to continue to be pancreatic sufficient if they're born pancreatic sufficient. But this will all be the choice of the pediatrician and the family because we are not providing drug. They will decide whether they're going to breastfeed or direct dose their infant. So I'll just say thanks to all of the people who participated in the workshop that was trying to figure out whether it was a good idea to design a study. And of course, like I said, we are designing a study, so everyone agreed that it was. And I think that's my last slide, and I'll turn it over to Dr. Wren.
And before we go to Dr. Wren, I'm just going to thank you so much, Dr. Taylor. That was fantastic. So much information packed in a very tight timeline. So thank you. And we're going to address the questions at the end of the presentations today. So I do want to just share the results of who's on the call, and we'll get to the longer answer results. But I want to share that for many of you, you've never experienced an infant who is exposed to a mother using CFTR modulators. But many of you have had this happen once or twice, several times, or frequently. And many of you have also had a normal IRT, which is what Clement is going to be talking about next, is what's the impact after all of this exposure to newborn screening. And then we have many answers on what worked well and what we might do differently. And we'll come back to that at the end. And then we have a good representation from newborn screening follow-up programs, laboratories, pediatric care centers, adult centers, and even some OBGYNs. So welcome to all of you. We're so glad to have you here. And with that, I will hand it over to Dr. Wren. Dr. Clement Wren is the CF Center Director at the Children's Hospital of Philadelphia and the Richard B. Johnston Jr. Endowed Professor of Pediatrics at the University of Pennsylvania. He is co-chair of the CFF-CF Newborn Screening QI Consortium and recently took over the position of the CFF-CF NBS National Facilitator from Dr. Phil Farrell. Dr. Wren.
Well, thank you. Thank you very much for inviting me to speak, and appreciate all the people attending. So yeah, I'm going to pivot, I guess, over to the impact of in utero ETI exposure on CF newborn screening results. Let's see if this works. Great. Oh, I forgot a disclosure slide. I don't really have any significant disclosures. So Dr. Taylor mentioned this briefly, but if we just kind of think about the primary effects of in utero ETI exposure on the infant are potentially preserved pancreatic function, potentially preserved vas deferens. There's now, I think, one case report of that. Well, there's actually two case reports. One in a mom with CF who was taking ETI. So the infant was exposed, or the fetus was exposed from conception. And then another CF carrier mom who received prenatal therapy. But I think the primary focus and most of the literature is really focused on prevention of meconium ileus, because, of course, meconium ileus is a very serious complication of CF that occurs in 10 to 15% of infants born with CF and usually requires surgery. In fact, usually requires two surgeries because you need to put an ileostomy and then you have to, of course, take down the ileostomy. And I think since we're really focusing on newborn screening, I'm only going to say a few words about the treatment of meconium ileus. Although if people want to put more Q&A, we can focus on that. But there's I put in two really good recent review articles. One of which Dr. Taylor's on, and the other is by the group in Denver that also, for people who are interested, summarizes really well the current status of the literature. But very briefly, in somewhat contrast to the animal model, prenatal therapy to prevent meconium ileus has been about 75% effective, and it's very dependent on when you start it in gestational age. And the later in gestational age, the cases that have not been successful have tended to be rather late in gestation, like 35 or even 36 weeks. So in some cases, mothers only took ETI for like a week or two prior to delivery. Okay, good. And again, just to summarize this, again, it's in the two review articles I mentioned, but there have been about 6 case reports or case series published with a total of 20 cases. And as I mentioned, the vast majority have been to treat meconium ileus. Some of them have been, quote, preventive in the sense that there was no sign of MI. So since not every baby with CF develops meconium ileus, we don't really know whether the treatment was successful in preventing it because they may never have had it. Treatment was initiated anywhere from 26 to 36 weeks. And as I mentioned previously, in those 16 cases where there was definite ultrasound evidence of MI, 75% of those kids did not require surgery. Some of them still required enemas and things like that, though. And again, it was more common if started later in gestation. We talked about pancreatic sufficiency, and once again, it's been variable. In fact, if you look closely, yes, many of these babies are pancreatic sufficient, but in fact, the majority still end up requiring pancreatic enzyme replacement therapy. And importantly, until our own case that I shared with Dr. Taylor, no adverse effects had been identified in infants or mothers. So let's turn back to newborn screening. As Dr. Taylor mentioned, that pregnancies in women with CF has almost tripled after introduction of ETI, and since those infants have, if the woman is having a child with a man who is a carrier, there's a high possibility that baby will have CF, and so. Sure enough, one woman with CF did in fact give birth to a baby with CF, and led to this case report by Chris Fortner in Syracuse, along with Denise Kay, who runs the newborn screening lab in the state of New York. And basically, they reported that in this woman with CF, who was taking ETI, the infant with CF had a false negative CF newborn screen and normal pancreatic function. So clearly, especially in infants who have been exposed to ETI since conception, it's very likely that their IRTs will be normal. Oops. Oh, good. Yeah, and so again, if you kind of look at that more closely with the subsequent literature, again, of the 16 cases that were where meconium ileus was suspected, 43% of those had a normal IRT. Just to share our experience, we've treated 6 women. In fact, we actually started treatment for the 7th woman last week. But of the 6 that have delivered, 50% of them had a normal IRT. In other words, a negative newborn screen. Sweat testing is kind of tough because a lot of times people haven't gotten sweat tests immediately, or the babies have been too small, as noted before. They can frequently be born prematurely, and actually lower birth weight for many years has been known to be a feature of CF infants. So a lot of times they're not big enough. So by the time you get the sweat test, it's quite some time since delivery. If you get the sweat test like immediate, if you're able to get a sweat test like in the first few days of life, it's almost always normal. But again, it can really vary. And as shown by Dr. Taylor, breast milk contains ETI, so that can also affect it. So the point here is that sweat testing these babies for diagnostic purposes can be challenging. I'm trying to see if it'll advance. Yeah, I think there is this lag thing. Okay. So what are some of the things that are important to address or think about in terms of postnatal follow-up following, I probably should just say in utero ETI exposure, whether through prenatal therapy or through a mother with CF taking ETI. So really, the postnatal follow-up starts with prenatal work and really we should try to establish the father's CF carrier status. That's important for both to estimate the risk, but also because it will let you know whether or not you can reliably detect the CFTR potential CFTR variants in the child. And then again, since IRT may not be reliable and sweat test may not be reliable, using doing DNA analysis on the newborn screen dried blood spot is indicated. And then the monitoring that has been discussed before, eye exam, liver function tests, and I actually mentioned lipase because in some infants, and we reported this, that in some infants, as the ETI is wearing off, they can actually develop pancreatic duct obstruction postnatally, and well, probably pancreatic cell injury because their lipases go up. And then finally, fecal elastase because it is possible that they will be pancreatic sufficient. Let's see. So perhaps we can discuss some of this in the Q&A, but I think one big challenge that this poses is really, again, identifying roles and responsibilities. And in particular, if you're going to do the DNA, if you're going to be doing DNA testing on the dried blood spot, since the IRT is going to be normal, somebody's going to need to contact the newborn screening lab. And there's few different options. The pediatric CF program could do it. The advantage of that is that in general, pediatric CF programs have some established relationship with the newborn screening lab just because we get involved in newborn screening overall. But of course, we don't take care of moms with CF. We do prenatal therapy, but not moms with CF. So somehow the pediatric program will need to know about the infant's birth. Adult programs hopefully are taking care, still providing care to moms with CF, but they don't usually have that contact and relationship with the newborn screen labs. And primary care providers, again, could potentially do this, but whether they have the time and the awareness to contact the lab is questionable. So I think overall, any of these things can work, but the most important thing is that CF centers and state newborn screening labs should develop a communication plan. And let's see, trying to advance. Okay, I talked about postnatal monitoring, so I don't think I need to repeat that. So I think in terms of successfully dealing with these situations, again, it all starts prenatally, talking to the mothers, especially women with CF, making sure that CFTR variant testing is done in the father, ideally through sequencing, so that you can look for, all the possible CF causing variants. Doing things like non-invasive prenatal testing to identify early on whether the infant has fetus has CF, and then doing postnatal DNA testing. And again, the theme really is good communication between the pediatric and adult CF programs, as well as between the newborn screening program and the CF programs. And I'll just give a shout out because I see Jordan Shover from the Pennsylvania DOH is on, and I think we've established a very good system within the CF centers in the state of Pennsylvania when we know about it, to quickly send a request to Jordan, who then forwards it on to Revity, because that's who does our DNA testing. And I believe that's it. Now we're to the poll.
Thank you, Dr. Wren. That was fantastic. Perfectly outlined the challenges and the benefits. So very much appreciate that. And we do have another poll that I'm trying to launch, and I can't figure out how to end the last one. So stand by. Okay. So this question really gets at some of the issues that Clement brought up, is who is responsible for facilitating that communication. What do you do, and how do you change your follow-up approach when you are you know that there's a CFT modulator in use? Do you collect this as part of newborn screening? And then what areas do you think you could have some improvement? And some of these questions actually came up in the last poll as well. So I'll give you a minute to enter your answers here. And then we can talk more in depth and go through the questions. So we still have a good amount of time to talk through some of these issues and then answer the questions in the Q&A. So if you have some additional questions, please put those in the Q&A and we will get to them. We'll give everybody about another 30
We need like
seconds.
Jeopardy music going during our little polls.
I was hoping you were going to sing for us, Megan.
No.
No.
I'll definitely get people to answer the poll quickly so it can be done.
Right. In the last poll, and we will summarize these results and share them with with all of the participants. But in what worked well, it was really the communication that worked well. When people said, "Hey, this was great," it's because we knew how to work through the system. So either states who've been doing it for longer, who said, "Yeah, we figured this out," or states who have one CF center. I think sometimes that can make it easier too when there's just a small group of individuals. But some of the challenges that came up actually related to Georgianne's question in the Q&A too about the small variant panel. If there's only 39 variants and there's a small variant panel, what do you do then? So all good questions. So I'm going to end this poll and share the results. So you can see, for the most part, the pediatric CF centers have responsibility for the communication of the modulator-treated infant. So that means the CF center needs to know about the modulator-treated infant, right? So if that CF infant is not necessarily identified by the pediatric care center yet, that could be a challenge. So what does your program do? Do you change your CFTR testing or follow-up recommendations? And yes, 20 states have a system in place to manage this. Some have it on a case-by-case basis, and right now, there's about 9 who reported that aren't changing things at this time. And do you currently collect modulator use? Some states, yes, we are routinely collecting it on everyone. Yes, but it's not consistent throughout the state. Most of you say, no, we're not collecting it. And a handful are saying we're thinking about adding it to the dried blood spot card. And I'll come back to that in just a minute, because I think that's an important consideration. And then what areas do you think you need help? And this could also help us with our ongoing collaboratives and future webinars, is where can we help you most? So adjusting the algorithms, improving communication, enhancing data collection on maternal modulator use, like how do we actually get that at the right places at the right times, and then educating providers and families. So thank you so much for your participation in this. And as I said, we will summarize these results and share them out with you. So briefly, some of the challenges. One of the challenges that I think we brought up earlier is there might be women who might not be seeing a CF care team regularly or don't have that communication, and maybe on a modulator, don't necessarily know the risks to the infant or the impact on the newborn screening results. So that's one challenge that could come up in this era where women are doing, many women are doing remarkably well. There are many states who are considering this collecting modulator use on the dried blood spot card. And my one word of caution is this is a rare exposure. So most newborn nurseries are not going to know about modulators. And when they see that result, see that question, they're going to say, what is a modulator? And they may or may not fill that in appropriately or correctly. Maternal chart and infant charts are typically not linked within a hospital system, so they might not have access to the maternal record, and you're likely to get limited or incorrect information. This is actually similar, I think, to what we get with meconium ileus for states who are collecting meconium ileus on their cards. Sometimes there's some challenges there too. So this could be an option in some states, but I caution you against going down too far down this path. There might be some other options. So developing a system, and I actually started pasting some additional ideas in here from the current poll and didn't get very far, but here are some recent experiences from systems that have worked. That in one state, the pediatric CF center sent a written request for the CFTR analysis regardless of IRT in moms who are exposed to modulators. And then the follow-up coordinator keeps the list of those with the estimated due date and watches for those to come in. So that's really on the newborn screening follow-up side is tracking that. Providers at the CF referral centers will request sequencing on an infant with modulator. So they'll call the newborn screening program. Some programs have cards that moms can hand out to say, hey, this is what's going on with me, and I need everybody to know this. So that's an active part where you put the mom in charge, or at least helping to be responsible. And this last one in the upper right, I just pasted in today, is that we see, this is from a pediatric care center, we received notice that from the adult program, that there's a baby who will need CFTR panel checked regardless of the IRT level. Often we receive this prior to the birth, but ideally in the first couple days of life. So there's lots of good ideas here, and now it's how do we create that system? So back to Clement's comment earlier about the keys to success, that we need to educate women who may be exposed to modulators, both women with CF and then women with a fetus who has CF, educating clinicians. That includes not only the clinicians on the call, the CF center, pediatric and adult centers, but OBGYNs, fertility doctors, others who might be treating women. And as Clement said, developing that communication system in state, that it's all the key players are involved in the state to know what's going on, so that eventually we can reflex to CFTR testing following IRT, even if there is a normal IRT. And finally, I just want to draw everyone's attention to this document that was put out a few years ago, actually, by the CF Foundation. And we can send this out with our summary of this meeting as well. But the clinical considerations of pregnancy, fertility, and CFTR modulators, and I'm going to highlight this section here, which talks about, given the risk of a false negative newborn screen, here are some of the activities that you should do. And we've talked about these already, so I won't go through them in detail, but we definitely will share this with you as we share the final recording of the call. So with that, I'd like to go to the questions, and I think, Megan, you've been monitoring some of the questions for us.
Yeah, so we have quite a few questions, so keep continuing to put them into the Q&A. So let's see. So one of the first questions for everybody is, what type of genetic testing do you recommend for infants exposed to modulators during pregnancy if your state's newborn screen only evaluates 39 variants? What do you recommend if the newborn screen has already been released as normal based on the IRT?
Clement, do you want to take that one or do you want me to
Sure.
take
No,
it?
I was going to say, yeah. Well, so that's why I think it's so important to test the father because if the father's F508 del, for example, and the mom is F508 del homozygous, then you're fine. But if not, you won't be able to rely on the newborn screen dried blood spot, and you would have to order standard, sequencing or something else. And again, I think the second part of that question again comes back to, education and prenatal counseling so that the PCP and the family realizes that the newborn screen may not be reliable.
Yeah, I think this is really the key of understanding what your newborn screen is and is not testing for, and knowing where you know what the parents' genetics are and figuring that out. So okay. So next one that we can do, has there been any guidance provided in the PROTECT study on diagnostic fetal testing and the type of CFTR variants identified? Our center is requiring clear genetic testing results showing two CF-causing variants, not just pathogenic, for ACMG following CVS and or amnio, although I worry folks may try to offer this after screening tests otherwise.
Yeah, that's a great question. And so first I'll say that Protect is under design. So we did have a working group that started to talk about the study design. We actually have our official design day at the end of May. And this is one of the questions that's going to be asked because in the French study, so the French have been doing this for about a year and a half, where they treat pregnant carriers or pregnant moms with CF with these modulators, and they are basing it on CVS or amniocentesis. There has been some thought that if there is a positive screening test and you have the variants of both the parents, then some people would still be willing to treat, but we haven't made that decision yet for Protect because again, our design day, when we get everybody in the room discussing it, including ethicists, is at the end of May. But it's a great question and one we're asking ourselves.
All right,
Yeah,
next question. Oh,
I was
sorry,
just
Clement.
going to follow up, like, because yeah, so I mean, I think that's the I think in general people have only treated once there's a
Yeah.
non-screening diagnostic test. However, but you could treat if there's ultrasound findings concerning enough, you could treat and you can always stop. The other option that might be available to some people, what we are doing here at CHOP is we have rapid targeted genomic analysis, RTAG. So like in this most recent case, we did the amnio, but we got the results back in like 4 days. So we were able to confirm the diagnosis very promptly.
Thanks, Clement. All right, next question. So should dosing of CFTR modulators in carrier mothers with a CF fetus be modified to decrease the dose that the fetus gets exposed to?
Yeah, that's another great question. And without knowing the pharmacokinetics of these modulators during pregnancy, it's a very difficult one to answer. Again, we have the Mayflowers data, and actually Chuck Esther, who's at UNC, will be presenting some of the PK data that we've collected to date. And he'll be finalizing that later this year. But we don't really know what the dose is that's necessary to prevent complications in the fetus. So right now, I don't think we have enough reason to modify the dose. So when John Engelhardt treated the ferrets with CF, it was the full regular dose that they treat any other adult with when they gave it to the CF ferret that was pregnant. So right now we just don't have the data to suggest that doing lower dosing is efficacious enough. For example, the VAS. We know that VAS deferens is incredibly sensitive to CFTR function. There are some males without CF who have CFTR variants that the only thing that they have is infertility because it's so sensitive to the VAS during development. So we don't know the answer to that, but right now I don't think we have evidence to say like, oh, giving half a dose is okay.
Thanks, Jen. All right, next question. Even without a connection to the newborn screening lab to do DNA analysis, thus like getting a normal newborn screening result, Shouldn't the fact that the mother has CF and is on a modulator be sufficient and prudent grounds for diagnostic testing of the infant? Clement, do you want to answer?
Sure. Yeah, but you can chime in too. Yeah, well, I mean, I think what the question is asking is whether you would just want to order sequencing on the infant, and I guess the answer is just is brought up in one of the other questions, which is that if then you have to go through insurance and all these other things, and you got to draw the blood on a tiny baby. So again, if you know the variants and those variants are on the NBS CFTR panel, or you're doing sequencing, it's just easier to just go ahead and do that. But I think that's what the question is
There's
asking.
a follow-up
There's
question, actually.
clarification too. I think it was sweat testing. I mean, this is really the
Mhm.
recommendation. So anybody
Mhm.
with a relative with CF should be getting sweat testing.
Yeah,
Although sweat testing a newborn is notoriously difficult.
yeah,
Right? QNS rates are high. You know, there's weight issues, all sorts of kind of things that go into it. So that's where the newborn screening, ideally, if you can get them to do the DNA analysis and the variants to test for the right variants, that's like the easiest way to get
yeah,
it done. Um, but I think this is really where a lot of this communication piece
yeah.
for thinking about how is your system gonna work and work every time across how it is, really thinking through some of these things. So, but yes, sweat test is always an alternative as a backup, but
Yeah, although again, if you do it early on postnatally, it could be normal.
yeah.
So again, do you want to wait a week or two? I mean, probably if you do it 2 weeks later, but then again, you're
If
waiting
mom is
2 weeks.
breastfeeding, that still can
Yeah.
affect
Right.
blood
Yes.
test. Yeah.
Exactly. Yes. Well, especially if the mom has CF and is taking ETI. Exactly.
Or if she doesn't have CF and she's chosen to
Yeah.
stay on it to try to give the
Yeah.
baby some
Yeah.
partial dose.
Yeah.
Um, all right, let's see what next one. So here's a question. So do newborn screen programs treat these modulator cases like meconium ileus cases where the IRT isn't as pivotal and DNA panels are used? I think that this is where newborn screen programs have started making changes. This is sort of where we've been able to get a lot of experience what happened in meconium ileus, where ideally you would know that that baby had meconium ileus or was on modulators for sure, and then you could just not pay attention to the IRT and skip right next to the next step. But for those of you who have had meconium ileus, as part of that algorithm, we all know the multitude of problems all around communication, right? The card is marked incorrectly. So you end up with all these babies who get marked as meconium ileus, when really that is the person interpreted that as past meconium. And so they marked on the card incorrectly. Or the piece of communication of like, how do you communicate that that situation to the newborn screen? If you have a system that's already really working well, where meconium ileus is like being correctly identified and communicated, then great. Like the modulators, you may be able to follow that. But most programs, there's a lot of holes in that communication for trying to figure out with those special circumstances. So I think whatever you're gonna do, you need to think through really extensively and think from a lot of different perspectives is how is it like what are the holes in your communication plan and what are the ways it's gonna fail and how can you have fallback levels of support to make sure that you're really catching these babies.
And there's a follow-up question to that about how newborn screening states are counting these cases. If it's a false negative, like if you're not identifying them, is that a false negative, similar to what you do with meconium ileus and how you capture those infants? So I think that's a great question, and we really need to consider that as we are calculating the sensitivity of our tests. That are you including those exposed to modulators in that result or not, similar to what you might think about for meconium ileus?
Yeah.
And we
And
have
that's where, like, if you think about who is analyzing some of those results, may be different than who you're actually calling. Like the newborn screening program, like most newborn screening programs have different teams. lots of people working on things. And so thinking about like, there may be lots of people you need to communicate to throughout the newborn screening program to make sure that some of these, like maybe the baby did get caught and you figured out that part, but now, yes, now you're having analysis problems and that may be affecting, decisions you're making later on. So that's a great question.
And Megan, we have reached the top of the hour. So I want to make sure we respect everyone's time. So there are some questions that are still remaining unanswered. And if our speakers are willing to do this, we might take these questions and type out some brief answers in response to them and send them out with our summary of the call today. So thank you so much. I think we could continue talking about this, and this really could warrant perhaps another webinar, another time for discussion to dive into some of these additional questions. So we very much appreciate all of your questions and all of your time. And I cannot thank our speakers enough. This was amazing. You guys gave us so much information to think about as we are moving forward with CF newborn screening in our state. So thank you, Dr. Taylor and Dr. Wren. Thank you all for your participation. And please keep an eye out for the follow-up from this call with the resources that we talked about today, as well as some of the answers to these questions and the recording of the call. So thank you all so much.
Thanks, everyone.